Welcome to our Medical Scholar Seminar this afternoon. For those of you who are not aware, this is our seminar series where we invite in practicing physicians who are also active researchers. And we love physicians such as the one you're going to hear from today because they blend this model of working with patients and informing their research based on what they're experiencing in the clinic. So I'm going to turn over the mic to Dr. Laura Hungerford, who's going to introduce our speaker.
Hi, so welcome. I'm Laura Hungerford. I'm the Department Head of Population Health Sciences at VT, but I'm also a member of the basic science research here and internal medicine. So I get to interact with a lot of people, which is great if you're an epidemiologist, but not as thoroughly on the medical side as our speaker today. So it's my pleasure to introduce today's medical scholar, Dr. John Mark Hirshon. He's currently a professor in the departments of emergency medicine and epidemiology and public health, my old department. And he is the clinical track lead for the Center for Advanced Research and Training and Innovation, all at the University of Maryland School of Medicine. He's also chair of the University of Maryland, Baltimore writ large, Institutional Review Board, and he's also the chief of emergency medicine for the Baltimore Veterans Administration Medical Center. He serves on, you'd think that would keep him busy, right? But he serves on and has leadership positions on a long list of institutional, community, national, and international committees. So he's really engaged in how does the research translate into what we actually do in public health and with patients. I know he plans to describe his path as a medical scholar, but briefly, he received his medical degree from University of Southern California, then came to Baltimore for residencies in emergency medicine and preventive medicine at Johns Hopkins, with training also at OSHA, and became double boarded. He simultaneously completed an MPH in international health and accepted a position as an assistant professor at Johns Hopkins. But then a few years later, he was lured to University of Maryland, where he's been for the rest of his academic career so far. While he was an associate professor, though, doing both clinical duties and research, he also decided to do a Ph.D. In epidemiology to deepen his population-based research expertise. During that time, he and I worked together, so that was great. And more recently, he was recruited to his VA activities in 2020. He has more than 130 peer-reviewed publications, 10 book chapters, and many, many, many invited national and international presentations. He's had sustained funding on a variety of projects, both within the US and internationally, from NIH, AHRQ, CDC, industry, foundations, and a lot of other places. His research focuses on population and clinically based questions in emergency medicine, both in the US and internationally, as well as educational programs that are evidence-based and human subjects research from his deep involvement with the IRB. So please welcome Dr. Hirshon as he shares insights from his journey as a medical scholar and his frontline position in emergency care. Thanks.
Thank you. Thank you. Can you guys hear me okay? Great. You guys are going to hate me. There's all this empty space down here. I'm going to ask you guys to come on down. I don't bite. My bad breath won't reach that far. So all you backbenchers, come on down. I like being disruptive. Yeah, you guys in the back row, yeah. Thank you. Okay. And while you're doing that, for those who are already sitting out front, you might as well get a pencil and a piece of paper out if you can. I know this is computer age, but what I'll have you do in a moment will be better if you have a pencil and a piece of paper. If not, you'll do the best you can. And you guys that are still up there, there's more rows down here too. You can. Got a little movement. Thank you guys for coming down. Now, I will also note, just to warn you guys in the back, that I have a lavalier mic, which means I can walk up there and cause trouble. So I'm John Mark Hirshon. I'm your presenter for today. As I try to put this presentation together, I went through a lot of different configurations. you know, who's the audience? What is it for? I've designed this for students for the most part. And so there's some basic information in there, but also kind of a perspective on how I got to where I am right now. Okay, feel free to ask questions. More than happy to answer. If you want to save them to the end, that's okay as well. So what I'm going to start off with, I'm going to talk a little bit about my personal journey. How did I get where I am? How did I get too many letters after my name? Those kind of questions. And just to kind of give you a personal sense of that. Then I'm going to talk a bit about emergency medicine and where we are right now, a very high level kind of conversation for those who might be interested. And then at the very end, a little bit of time to talk about advocacy and engagement, which I think is incredibly important. Okay. So let me start off with the journey. Okay. But before I get started, this is where the pencil and the piece of paper is going to come in. Okay. Is one of the things you have to understand about learning and making decisions is that it's based on a combination of what you know and what you perceive. Okay. So let me get the other. So if you take a look here, you'll see that you're trying to make meaningless information into meaning. Okay. But recognize that a lot of this is based on what you know and what you've learned. So you're going to make meaning out of meaningless information based on your background and how you organize your thoughts. So I want you to take a moment. I want you to memorize these symbols and those numbers. I'll give you about a minute or so to do that, okay? Take a look, try to memorize them. I'm giving you guys about a half a minute, but one of the hardest things in meetings is sometimes the silence, okay? So now what I want you to do is I want you to draw those symbols. I just had a half minute and 45 seconds so see how well you can do drawing those symbols. All right. How'd you do? How many of you, move it down. Here they are. How many of you got one right? Very good. How many of you got two right? Good. Three? Excellent. Anyone get four? Good. Anyone get five? Just checking, okay. But what happens if I were to give you a conceptual framework to do that a little bit better? What happens if I showed you this instead? Okay. So there's 6, there's 1, there's 4, there's 9. So if you were to go back and do that exercise again with that conceptual framework, would it have been easier? So part of what you have to do as you go through this process of education, we're giving you a lot of factual building blocks. But what's the conceptual framework that you're going to use, okay? Because you understand now that a conceptual framework will allow you to use your building blocks in a more efficient manner, okay? So you need both the factual knowledge, okay, as well as the conceptual framework. So the first question I'm going to challenge you with, not to be answered, is what is your conceptual framework, okay? The way I often phrase it is, what do you want to be when you grow up? But it's the same kind of concept. You know, how are you going to put together? You have all this information. You're going to be making significant decisions as you go along. How are you going to put that into a way that's going to work for you? Okay. One way to approach this, and this is more the academic professional side of things, is to do what's called an individual development plan. So the purpose of the plan is to make you write down on a piece of paper what you want to accomplish. Now, do you have to do exactly what's on the plan? No. But by making it concrete on a piece of paper, it gives you this kind of sense of firmness or concreteness that, well, gee, I might want to do this. I might want to do that. Oh, look, this is what I have written down. An individual development plan has a couple components. So first, it's about you. Okay, you're the one who's going to have to write it down. You're the one who's going to have to think about it. You do this with your mentor or your teacher or your partner, someone who's going to kind of help you think through those questions. Okay. Then you have also, what are your goals? Your short-term goal. My short-term goal is to get through medical school. I can understand that. My long-term goal is 3+ years to get through residency. Okay. How are you going to get there? What are your objectives along the way? So you've got these longer term goals, but you have these objectives along the way. And I would say, as an aside, when you're talking about research, you'll have your specific aims, and then you'll have each of your objectives to how you're going to accomplish those specific aims. Because the bottom line is this: if you aim at nothing, you hit it every time. Okay. And so the idea here is that you're going to have something to shoot for. And even if you're not successful in reaching that objective, then at least you're going to have moved forward in what you want to do. Here's another example of an IDP. I particularly like this one because it was very colorful. But on top of that, if you will, it has nice domains to look at. Okay. And this is from the University of Hawaii. Okay. So it doesn't have to be the dry federal bureaucracy form. It can if you want, but there are other ways of doing this. But the idea behind this, it's about you. It's about where you want to go and how you want to get there. So let me take the journey for a moment to talk a little bit about me. Okay, Dr. Hirshon was, which of these is not correct, not true? A college dropout, a dessert baker in a restaurant, elected to both medical and public health honor societies, chairman of the board of a national medical professional association. None of the above, all of the above. Okay, how many of you think I was a college dropout? Okay. How do you think I was a dessert baker at a restaurant? Elected to both medical and public health professional societies, honor societies, chairman of the board of a national medical organization. The answer is all of the above. Okay. Yeah, I dropped out of college. Why did I drop out of college? I don't know why I was there. Okay. After high school, I traveled through Europe for a year, worked on a kibbutz in Israel, worked in a factory in Germany, came back, started at UC Santa Barbara. I was there for about 1.5 years, and I'm like, why am I here? I want education. I know I wanted to go to college, but I couldn't tell you why I was there. Okay, so I dropped out, and I became a hippie in Northern California in the 1970s. Long hair, the whole works. Worked as a dessert baker. I still like baking. Now I do breads and stuff like that. Our home bread now is a sourdough ciabatta roll that disappears pretty quickly when I make it. I lived in a place called Mendocino. Anyone from California here? Okay, Mendocino is up in Northern California. It's in the middle of nowhere. It's very pretty, very nice. Quick story. So I told you I'm a hippie, right? So I'm hitchhiking north in California. I'm stopping in Santa Cruz to visit some family, and I'm going to hitchhike up to Alaska. Okay, so I start hitchhiking north, and I land in Mendocino. Now in Mendocino, it's very small. It's like a New England town in California. And I'm walking along with my guitar and my backpack and everything else. And a guy says, well, I hope you have a good trip. I'm like, well, I just arrived. He says, so I started talking to him, an older guy and all. And he was the manager at a hotel. He said, I'll tell you what, if you need a place to stay, you can stay in one of the rooms. Don't sleep in the bed. You can sleep on the bed type thing. But, it's okay if you stay there. I said, okay, that's really nice. Thank you. So I put my stuff in there, wandered through town, wandered into a small gift shop. And I decided out of the blue to buy my father a gift and send it to him. So I did that. Next day, I have my stuff. I see the guy went up to thank him, said, "You have family here." I go, "What?" "Yeah, it turned out that at the small gift shop, my great aunt was working, but she had gone out for lunch, so she wasn't there. And so all of a sudden I had family there. Within 2 days, I had a place to stay, I had a job, etc. So it was an opportunity for me. I could have gone on to Alaska, but I ended up in Mendocino for 1.5 years, 2 years. The point behind that is it was an opportunity, and I was willing to take it. Okay. Now, you may find other opportunities, maybe not being a dessert baker in Mendocino, but as you go along, you have to decide whether you want to do that opportunity or not. While I was there, it was before they had IDPs and stuff like that, and is really, I don't know, very many hippie mentors type of thing. I sat down and said, what am I really interested in? If I'm going to go back to college, if I'm going to go back and get additional education, why? And so I said, I came up with 3 things. I thought health, travel, and music. And those are things I liked, okay? So with health is, I think more now you can do study health, but really medicine is the profession. Medicine is not the same as health. And as you guys go through medical school, you'll start realizing that both on a population and individual level, health is something different. But medicine is a well-paid profession. Could help me work on health. That would be good. For travel, I decided to do global health. We called it international health there, but it's global health. And then for music, it's a passionate hobby. I play a mean stereo is what I used to say, but I used to play guitar, harmonica, things like that, but it's been quite a long time. So I went back to college, okay? And I went to UC Santa Cruz, banana slugs, okay? Went to USC for medical school, and then I went to Hopkins for both my emergency medicine and my preventive medicine residency. Now, when I went to Santa Cruz in the mid-'80s, we didn't have grades, okay? We only had narrative evaluations. So can you imagine the transition from undergraduate to medical school? Was a little bit of a challenge for me. Hippie, Northern California, a traditional path, college that doesn't have grades. I got in, I was waitlisted, got in the first year, and I decided, you know what? I didn't like the feeling of not having a little more control over my transitions. So another key point in my career and my life is that I decided to excel, okay? I had the capacity, many or most folks here have the capacity. It's a question of how hard you want to work at it and how do you find that right balance, okay? But for me, I decided that if I'm going to do medicine, if this is my career, this is my path, this is my life choice, then I better do a damn good job at it, okay? And so that's when I decided to start excelling. Okay. I just want to make sure I'm not missing any good stories, so give me a second. So I went to USC, and then I went to Johns Hopkins. Now, part of the reason I chose to go to Johns Hopkins is because I wanted to get a master's in global health, and international health, as it was called. And so I went there, I did my emergency medicine residency, and then I decided I was going to do, I want to get my master's, but it's kind of expensive. And I'm, just out of residency and stuff like that. And if I did a preventive medicine residency, they'd actually pay part of it. And I would be able to go on an international rotation as part of my second year. So I did 5 months in Jamaica doing measles elimination, measles surveillance and polio surveillance work. So I went to Johns Hopkins School of Public Health, excuse me, now the Bloomberg School of Public Health, and got my preventive medicine residency and did my MPH. Now the MPH was, I wanted to do global health, so it was like building latrines, stuff like that. I did statistics, but not as much as I came later to desire, but it was really, really good. Really good. And so after that, I decided to do the finishing school of emergency medicine, which was to go work in the community. And I was actually doing that as part of my, part of the time I was doing my preventive medicine residency. So I did the finishing school of emergency medicine, and then I came back to Johns Hopkins to start working kind of academic. So I knew that just clinical emergency medicine was not going to be enough for me. I love clinical medicine, but I like other things as well. I'm looking for that right balance from a career perspective. I knew if I just did emergency medicine and from a clinical perspective would not be enough. So I came over to Johns Hopkins, was there for a number of years teaching and all. Part of what I was doing at the time was I was interested in emergency departments as a source of surveillance. So really real-time or near real-time surveillance for infectious diseases and those type of things. And so I was doing some work with the Baltimore City Health Department, and I got to meet the department chair at University of Maryland who enticed me over, and I've been at University of Maryland ever since. At University of Maryland, I did a number of grants. Interestingly enough, 3 or 4 of those are either career development or training grants. So where I've really focused a lot of my career is on teaching. But teaching not clinical at the bedside, I do that too, but teaching how to do research and the thought processes related to research. Now, I'd shown a picture of University of Maryland previously. So right here, this is the oldest still being used building for medical education, I believe, in the country. I want to say it's the oldest public health school of medicine that still is in existence. So while I was there, I had a mentor who was the head of the Department of Epi and Preventive Medicine, as it was called at the time. And he suggested I write a grant. And so I went ahead and wrote a K grant, which is a career grant. Okay. Now, a career grant has 2 components. It has a research component and an educational component. No one told me, I could blame my mentor, I could have looked it up probably, that the education component doesn't have to be a degree. So I said, I'm going to do a PhD. Why not? You know, something to do on the side, etc. So I committed in my K grant to do a PhD in epidemiology. I took all the classes, some of them taught by Dr. Hungerford and others. And I finished all the classes and I had to complete my dissertation. And so finally at one point I said, are you going to complete this or not? I made a commitment to complete the dissertation. My K grant was way gone at this point. The data I was using was actually going to be from the UO1 I had, but the data wasn't very clean. Okay, but I said, I made the commitment, I'm going to complete the dissertation. So I completed the dissertation. I'm really glad I did because I learned a lot in that process alone about what it means to have to complete the project like that, what it means to have to use dirty data, as I say, to try to write grant or to try to analyze it and all. I had great mentors. One of the stories I love to tell is, I was trying to figure out what study design this was. So I asked 3 of my dissertation, committee team, and I got 4 different answers. So it's never as black as white as you think, but the process of completing it taught me a lot about epidemiology, about myself, and what was necessary. And so a lot of what I teach, going back to what I said, is really epidemiological methods, because I know what it feels like when you don't do it right. Okay, there's things you can correct with analysis. There's things you cannot correct with analysis. If you're going to do research, do it right. So one of the grants here is my D43 on injury prevention research training. Okay, and so typical John Mark style. So I'm at the National Study Center for Trauma and EMS, and I've decided that I want to do a training grant, a T32 it's called, to teach injury research methodology domestically. Okay, and so we met with the folks down at NIH, and I was thinking about how to do this. I didn't throwing things around. Sorry, I didn't I didn't have the street cred, as a friend of mine likes to say. So I was going to have someone else as the PI. But someone who did a lot of research in epidemiology and injuries. But before I did that, an opportunity came up to do an international one. And I said, well, gee, I like international work. Okay, I've been down in Jamaica. There's a lot of trauma in Jamaica. You know, why don't I do a grant on this? It'll be good practice even if I don't get it. And my mentor and the folks in Epi said, well, you know, we've got this really strong relationship with Egypt. So why don't you do it for Egypt? I said, okay. And someone gave me some data. I wrote the grant up, and I got it. Okay. We got that refunded 3 times. And the last cycle we did not. There's probably structural reasons why that occurred. But, you know, through that program, I went to Egypt. We trained in Sudan, Lebanon, Saudi Arabia. I went to a lot of Middle East. Did I think I was going to be going to the Middle East when I planned global health? I came from Southern California. I was going to go to Latin America. But I spent most of my career, international career, working in the Middle East. And one of the things I like to say is my trainee success is my success. So one of the proudest things, one of the things I'm most proud of is one of my early trainees is now the president of the University of Egypt. Okay, so I feel very honored. He wanted me to come over and work for him, and I got a commitment. I'll come over later, you know. But so we did this for 15, 18 years. We trained over 1,200 students. Sorry, and it was a lot of fun. It was a great success, and I really enjoyed it. And there were great people I worked with in that process. But I also did stuff on the domestic side, right? So one of the things I'll mention later is that I firmly believe that you need to be engaged in what you do. What do I mean by that? If you're working at a hospital and you're just a community doctor, you better be on those committees for that hospital, because the hospital is going to make decisions about your career and what you're doing. And if you're not there, then they're going to make it without you. Okay. If you're doing population health and you see there are problems on a national basis, then why aren't you doing some advocacy work for it? Okay. Or at the state level. Okay. So you want to be engaged. And I have a slide that says this later, because if you're not at the table, then you're likely to be on the menu. Okay. So this is the FACEP board of directors. I ran for the board. I was asked earlier about burnout at the small group. And I said, one of the things for me is that my professional society is kind of my peeps. You know, the people I hang out with. I've been going there for 30-something years. And I get a lot of, you know, I'll drag in after like 6 months of, you know, just mind-numbing administration. And it's where I recharge my battery. So I decided I was going to run for the board of directors. Okay. I ran for the board of directors. I needed about 150 votes. I got 125. Not bad, first time. Okay. So I ran the second year. Now I assumed that, you know, they would reward perseverance. So I was going to be all excited about getting elected, and I got 125 votes. And what Einstein said was that doing the same thing over and over again and expecting different results is the definition of insanity. And I may be insane, but I'm not that insane. So I sat back. I watched. I got very good at handicapping who would win and who wasn't. And in my self-analysis, I realized that what I needed to do was become a better public speaker. So I got a speech coach. Okay, and he worked with me, he helped me and everything. So I ran a third time and I won. And not only did I win, I beat an incumbent. And you don't do that very often. In fact, the last time anyone beat an incumbent in my professional society was me, 10 or 12 years ago. Okay. But even though this is one of the pictures, I actually like this picture better. Come on, be nice to me. There we go. I think that's a much better picture of the board of directors. So the board of directors, when the president goes off, they buy a thing for the board of directors. This tie, for example, is one of the things that, so one of them got us all bobbleheads. Another thing I say is that the journey is a lot nicer when you have people to do it with. You know, you can do it by yourself, okay? But it's really nice when you have other people with you. That's a friend of mine, Steve Anderson. We both got elected at the same time on the board. We were both on the board at the same time. He was chairman of the board the year before I was chairman of the board, and we remained close friends. But the ability to work collaboratively and have people to work together, whether it's in the medical field or in your research field, is a critically important skill to develop. So there's a Japanese proverb, fall down 7, get up 8. If you write grants, you're not successful every time. If you run for election, you may or may not be successful every time. But you have to figure out what it is that's going to allow you to be successful. And one of the key elements of success is perseverance. Fall down 7, get up 8. So that's kind of a quick life journey. As I like to say, life is not linear. I've done a lot of different things. I still do a lot of different things. I've been, you know, if you look at letters after my name or, you know, titles, I've done a fair amount of stuff. I like doing what I do. It can get overwhelming sometimes. I can get tired. I did not have an IDP that says this is what I was going to do, but I did start off with a focus. Okay, and my purpose and my desire to excel helped me move forward. Now, I'm going to speak a little bit briefly. I'm going to transition and speak a little bit briefly about the emergency department. This is a very high level thing because I'm not sure the level of folks. Okay, so what is acute care? What is the unifying aspect of everything that's up on that slide? Okay, that's a good start. What does that mean? I'm sorry? Sick patients, not all of them, urgent care, but a lot of, go ahead. I'm sorry? Their care in general. There's one aspect about emergency medicine which is different than almost every other specialty. We do time-sensitive care. Everything up there is time-sensitive. Is it critical care? Is it trauma response? Is it acute surgery? Is it emergency care? Even urgent care tends to be a time-sensitive condition. The rest of medicine is almost all organ-specific. I do broken bones. I do eyes. I do kidneys. Okay. We do people. We take care of people when they most need it. So it's a time-sensitive aspect, and emergency care is one aspect. There's others, like I said, trauma and acute care surgery. You can do critical care, pre-hospital care, but these are all time-sensitive conditions or situations in which you have people with potentially serious conditions. So I talked about, you know, spending time in Egypt, and I also talked about time-sensitive conditions. And I use this picture quite a lot because this was just a random picture a colleague of mine took on the streets. And if you take a look at this, and things have changed, but there are a number of issues here that I find from a population perspective and an individual perspective concerning. Okay, so here's a person trying to cross the street. Okay. People would ask me, isn't it dangerous to go to the Middle East? And what I would say is the most dangerous thing I do when I go to Egypt is try to cross the street. There's no zebra crossing, you just cross through traffic. I got very good at it. So doesn't mean it's not risky, I just got good at it. Okay. Wake up. There we go. Oops. So that person hanging out. If that car stops suddenly, what's going to happen to that door? Okay. But the one that really bothers me the most is this one. A little kid in dad's lap, right? In an open car. That car stops, all of a sudden, what's going to happen to that kid? Projectile. That kid may then become injured for the rest of their life, a burden to them and their family if they're not killed outright. Okay. So when I interviewed for my preventive medicine residency, I was asked, well, you did emergency medicine. Why do you want to do this? I said, after a while, it's kind of the yin and yang. I take care of enough people in the emergency department, like, kids with head trauma from bicycles. You start asking, why isn't there bike helmet laws? Okay. And after a while, you do public health and policy and stuff like that. It's like, I want to get back to taking care of the kids. So to me, it's yin and yang, but this is an example of why what I do is focused on improving access to emergency care and trying to prevent injuries and disease before they happen. Now, let me ask you real quickly, how many of you have been patients in the emergency department? How many of you have had family members who were patients in the emergency department? For those who didn't raise your hand for either, you're lucky. Okay. And we'll talk a little bit more about that in a moment. So in 1966, recognizing this is, Egypt many years later, there was a paper published on accident and death and disability, the neglected disease of modern society. It was a pivotal publication by, I think it was NHTSA that did that, National Highway Safety and Traffic Administration, that talked about the need for improved care. When you look at emergency care 50, 60 years ago, if you went into the emergency department there, who would take care of you? I'm sorry, what? If you were lucky. Surgeon, whoever was there, okay? And historically, what that was is the person who couldn't get into a practice, who'd sold their practice so they were retiring, no one wanted them in their practice. Okay. If you were in an academic center, it would have been the intern, maybe a resident if you were lucky. Okay. When I had a friend of mine who was going into anesthesia, and his dad had been an OBGYN in San Francisco for many years. When I told him that I was planning to go into emergency medicine, his face dropped. Because to him, that's where the incompetent people went. Okay. And that was in the 1980s. So historically, emergency medicine was not a very valued perspective, specialty. But we knew there was a need. Okay, so in 1967, the American Medical Association developed the Committee on Emergency Medicine. Okay, 1968, the American College of Emergency Physicians was started. Okay, 1970, there was the University of Association of Emergency Medical Services. That actually complied with science. Sorry, these are old terms. So the Society for Teachers of Emergency Medicine to develop into what was called SAEM now, which is Society for Academic Emergency Medicine. Okay. The 1970s when the first emergency medicine residency was developed. Okay. The 1974, the Emergency Medicine Residency Association was developed. This is not that long ago. We're talking, 40, 50 years. Okay. 1976, the American Board of Emergency Medicine is incorporated. 1977, they took the idea of an emergency medicine specialty to be voted on, and it lost 100-5. But fall down 7, get up 8. They went back in 79. They became the 23rd specialty. They did it as a conjoint board with others, so that way there was support of a group. Ultimately, they became an independent specialty. I mentioned 1993 when the academic emergency medicine was incorporated. So this is kind of the history in a quick nutshell of how emergency medicine developed from whoever was there took care of you. And in fact, in some places, there wasn't even a doctor. Oh, you look sick, let me call the doctor in, okay? To where we are right now. So emergency medicine is challenging in many ways, okay? In the 1980s, there was the Emergency Medicine, EMTALA, Emergency Medicine Treatment and Active Labor Act, which made it a requirement of emergency departments to take care of people, not transfer them for financial reasons, especially if they were about to deliver. In 2006, the Academy Institute for they changed names, sorry, give me a second. The Academy of Medicine is what it is now. So published 3 articles or 3 manuscripts on emergency medicine. And if you take a look at the first one, which was the general one that they did, this is hospital-based emergency care at the breaking point. Fast forward to 2023, it's still at its breaking point, but we don't break. We keep working. There are a lot of challenges that we face. We'll talk about those in a moment. But we function in a non-system system. Okay, there's a lot of lack of coordination. There's a lot of special interests. But what I do in the clinical emergency setting is I take care of patients. Okay, 24 hours a day, 7 days a week, 365. There's always somebody in the emergency department to take care of you or your family member if you come into the emergency department. So where are we right now? In 2021, so let me just give a little footnote, 2021. What year did COVID start? 2020. So 2021 was kind of a nadir in terms of numbers, okay? And we're seeing the numbers come back up right now. But in that year, we had 140 million emergency department visits, okay? Of those, 40 million were injury related, okay? The number of visits per 100 people in the US, 42 points, so 43 visits per every 100 people. Now, know your data, visits are not people. So this is, someone can come in. I had a patient who will remain nameless, 93-year-old guy, really sweet, lived by himself. When he lived in a high rise, when his sister died, he really had nobody else. He came into the emergency department where I was working 550 times in a 2-year period. Okay. And did we help him? No, he was lonely, you know, and so it becomes a societal question and something like that. So it's visits per 100, it's not people. However, out of that 140 million visits, 18% of them, a little more than 18%, required hospitalization. And almost 3 million of those required critical care. So if you ask me, what do I see as the future of emergency medicine? These numbers are not going away, okay? They're only going to grow. And they are growing now. This year, the data is not out yet for this year, but looking at the stuff from 2022, from a different source and all, the numbers are back to where they were in like 2020, 2019. So we're going to continue seeing this, okay? Current challenges. So when COVID started, we were viewed as heroes. Not just emergency medicine, but medicine in general, okay? I remember taking care of the first patient I had with COVID. We didn't know he had COVID. Okay, it was March of 2020. And he was a young guy, like 30-something, 38, 39, had a lot of comorbidities already. We ended up admitting him. He was in the hospital for like a month and a half. Okay, but he went home. Fast forward to last week, he came in, heart failure, went into cardiac arrest. Okay, that's my job. I take care of people. Sometimes we do better, sometimes we do worse. But COVID really went from heroes to, it became a real challenge. There's a large amount of burnout, not just in emergency medicine, though if you look at the numbers, we're one of the highest ones, if not the highest. Because I'll tell you, it's been a rough 2 or 3 years. Anyone who does clinical medicine, who has, you know, if you're taking care of patients, it's been a rough several years. Okay. And how do I deal with that? Well, I do other things. I have research, I do administration. I meet with my friends from American College of Emergency Physicians. Last month, I played hooky and ran away and hiked the Appalachian Trail in the Great Smokies. Okay. So, but you know, I can't tell you what you need to do for your mental health, but you have to find the right balance. And one of the things I have not done well for most of my career is I've been a workaholic, and I'm really now trying to say, well, maybe considering what's happened in the last couple, 3 years, I need to start giving a little bit better to myself. I need to advocate for myself. Okay. And Maryland, a little state up there, has the worst when it comes to metrics in the hospital. They have the highest boarding rate, or one of the highest, and one of the highest times to be seen in the country. Go ahead. Wow. You know, it's funny. I had their Senate staffers were through the hospital at the VA where I was last week, and they asked the very same question. The quick answer is that the funding mechanism in Maryland is different from the rest of the country. It's called global budgets, and it's all under one group. There are a lot of other reasons for it as well, such as staffing in the hospital from nurses and things like that. But for the Senate staffers, I gave them the one-word answer. So, because that, and we've published on that, looking at some of those things, but it's to a large extent how healthcare is funded in Maryland. So, it's not the only reason, but that's part of it. Now, I'm at the VA, so they measure me by different metrics. So I can't live by what they do in the state. I have to live by what they do at the VA, and my metrics are much better than my colleagues. I hate to say them sometimes because they're usually so much better. And this is just to show the example of average, ED arrival to inpatient admission time for psychiatric patients. And you can see that for some of these people, this is in minutes. So you're talking some people that have what, 1,400 minutes. Think about how long that is for a moment. I have friends who tell me stories about mental health patients. The hardest are dual diagnosis adolescents who've been in the ED, in the emergency department, for months pending placement. Okay. Maryland's a little bit better than some of the other states, but the issue of boarding has now become a national problem, and there's a lot of the conversation about this and how we need to address it. Okay. So we're thoughtful people in medicine. We're thoughtful people in emergency medicine. And so we ask the question, will there be jobs? Okay. So FACEP put together a panel to look at it, and their projections were there's going to be a surplus, et cetera. This was before COVID. Okay. So if you take a look at this, from 2021, this is unfilled rate in emergency medicine. Historically, emergency medicine was either the highest or one of the highest in terms of fill rates. We'd have, I forget the number, 1,200 slots in the country or something like that, and we'd have 5 empty slots at the end. A number of things have changed. There have been an increased number of residency positions. There's been COVID. There was a lot of conversation about, where will emergency medicine be? And so we saw last year or so, a significant increase in the number of unfilled slots. But I'm here to tell you, will there be jobs? Yes. How can I say that? We can't even fill slots now. I mean, it may mean that you have to work a little bit, or you won't get that premier job next to the academic center. If you look at the literature, at the statistics, where you trained or like where your family is, these are the predictors of where you practice. How many academic medical centers are in rural environments? I don't know, but I don't think there are many. Okay. So how do you get people out to those areas? And can you get a job in an academic center? Yes. Perhaps you'll have to do a fellowship. You can't walk out. From the 5 years before I started training, there were people who walk out and got department chair positions because there were just not a lot of emergency positions. So the job environment may be different, but the demand for our services is going up. Okay. So I talk about kind of emergency medicine from a larger perspective, but as I've mentioned many times, to me, it's about the people. This is Mr. Ezra Hill, okay? I took care of Mr. Ezra Hill a couple years ago in February. He was the oldest patient I ever took care of. He was born in 1910. He was 110 years old when I took care of him. Really nice man, very hard of hearing, But aside from that, and as kids, I'm your parents or maybe your grandparents' generation. His kids were my parents' generation. Okay. It is an honor for me to be able to take care of people like that. Okay. And so that's why do I do emergency medicine? For folks like Mr. Hill. And for me, I'm the chief of my department. So one of the things when you look at organizational structure and kind of culture, what the top person says makes a difference and pervades throughout the system. So I have three key principles, three operational principles that I go with. Okay. So first, I want to be able to provide exceptional emergency care to our veterans. I may not be a veteran, but it's an honor for me to serve those veterans. Second, I want to make sure I have a supportive and positive environment for our staff and colleagues. How well my emergency department works is how well my staff works. If they're not happy, I can't meet mission number one. And last, I'm very aware of the future. So I want to be able to provide an outstanding educational environment for our trainees. Okay. Am I successful with this every day? No. Are they aspirational? Yes. Okay. But if I aim at nothing, I hit it every time. So in this whole journey of emergency medicine, I've talked about my professional colleagues, I've talked about people. And one of the things I learned working in Egypt, okay, was that if you want to go fast, you go alone. But if you want to go far, you go together. And what's important in your careers are who are the people that you're working with, you're collaborating with. How do you work in a collaborative environment? You're not going to be a solo practitioner. The likelihood of you being a solo practitioner is very, very low. You're going to be working with in a center with professional colleagues, etc. How do you work collaboratively? How do you work together? Okay. Last little bit is talk a little bit about advocacy. Okay. And if you think that looks like I'm testifying before Congress, I was. There was a congressional subcommittee. Okay. As I said before, if you don't speak up, if you don't advocate, they won't hear your voice. Okay. So if it's in your practice, in your hospital, emergency medicine in particular, this is really important because the contracts can change and stuff like that. So I want to be there to make sure that we're advocating for our patients, advocating for my staff, advocating for my trainees. Or you could do it at national and state, wide. If you do population health related research, you realize the impact of policies on our patients. They may be financial policies, they may be other health policies, but if you and your group aren't there advocating, no one's going to hear your voice. Okay. And then last, I'd asked earlier about how many of you had been to the emergency department, how many of you had family or friends in the emergency department. I strongly believe that when you're a patient, have someone with you. Okay. If you're sick in the emergency department and you got a broken leg, how are you going to advocate for yourself? Okay. If you're admitted to the hospital and you're sick and you're intubated, how are you going to advocate for yourself? It doesn't mean that you have to have a medical professional, but you should have someone there who's going to be able to speak for you. I don't think he would want this. Okay. I think that's a good thing. I think he would agree to that. Or let's hold off until we get more people together so we can make a decision. Okay. Because as a physician, my job in the emergency department is to make decisions. I make decisions all the time. Now, is that what the patient wants? I need to ask, why are you here and what do you want? Okay. And if you can't tell me, who is going to tell me? Or as I said earlier, if you're not at the table, you're probably on the menu. Okay. With that, I'm going to go ahead and finish up with some closing thoughts. Life's journey is not linear. okay? You could be a dropout and still be up here talking about things, right? Enjoy your path. Be aware of the destination, but the vast majority. So like when I hiked in, the Great Smokies last month, right? I was going to end. It was going to be, but it wasn't. I wasn't focused on that. I was focused where I was. What was it like? How wet I was, things like that. It wasn't always a pleasant journey, but that's the nature of journeys. Okay. Okay. Having company along the way helps. Okay. The U.S. health system is, I like to say it's a non-system, to be frankly honest. It's fragmented, it's inefficient, it's ineffective in many ways, but it's the system we work in. It has advantages, it has disadvantages. Emergency departments play a key role in the U.S. healthcare system and will continue. Emergency departments are the key interface between the community and the hospital. You could say they view it as the door to the hospital, even though there's a front door. Almost all admissions, or 2/3 of the admissions, come through the emergency department, and we can see what the community ills are when they come to us. So that's why I was looking at it from a surveillance perspective. Okay. And we all need to work together to improve the experience of the patients and the care we deliver. Engagement is key. Physicians, scientists, your learning is lifelong. Okay. How are you going to continue to learn when you leave? What are the skills they're giving you right now to allow you to continue to learn? In terms of engagement, strive to improve yourself and to improve your environment. Remember to advocate for yourself, your family, friends, and your specialty. And remember to have fun. You're only going to be doing this once, okay? So in emergency medicine, what we say is you work hard, you play hard. So have a good time. And I thank you for your attention. All right, questions? Hit me with them.
Hi, thank you very much. Could you maybe verbalize some reasons why you think people in medical school should go into emergency medicine, or reasons you think it's still a specialty that people should pursue?
All right. So let me ask you a quick question. How many of you have seen Dr. Glaucoma Flecken? Okay, great. So who does he portray as the emergency physician? The guy with the bike helmet, drinking lots of Diet Coke, etc. Every medical specialty is different. There are different personalities in each one. You don't have to have that personality, but emergency physicians are a fun group. More importantly for me, from a cognitive and emotional perspective, is that, so when I was trying to decide what I wanted to go into, I wanted a generalist specialty. I also wanted the flexibility that emergency medicine would give me so I can do international stuff. But from an emotional perspective, I imagined myself, I'm going along in my car, I'm in a car accident, I'm lying on the side of the road, all mangled. This guy pulls up and jumps out and says, "Hi, I'm a doctor." And I say, "What's your specialty?" "I'm a dermatologist." I'm like, "It's okay, I'll wait for the paramedics." Yeah. So for me, I wanted to be able to take care of people. Okay. If you're ever, when we're on a flight, right, there's a medical emergency, right? You go there, and there's like 3 other people. As soon as they're emergency medicine, they become ghosts. "Oh yeah, you can take care of the patient, thanks." So for me, it was, I wanted to be able to take care of people. Okay. And I want to take care of people who need my care. Okay. And I didn't care about the money in the sense of, well, gee, I need to have a practice and this and that and the other thing. We take care of people. We provide uncompensated care, millions of dollars of uncompensated care a year. And I don't care if you're the CEO of the hospital or a person who lives on the street. My job is to take care of you and provide the best care I can. So I think that to me is the reason I went into emergency medicine. Good question, thank you. Other questions? Go ahead. A microphone there. Thanks. I think they're recording this, so they prefer to hear. Yeah.
Hi, yeah. I was curious. It seems like you've been pretty successful at keeping opportunities to learn like open throughout your career. I was wondering if you have any advice to all of us on how to do that throughout a career in medicine, like how to make sure we still have those opportunities to keep learning.
So it's hard sometimes. So when I started kind of academics, I'd write papers and get them back, and they'd be full of red marks and stuff like that. And I'm like, oh my God, this looks terrible. And then I realized over time that someone put the effort together to criticize it. Okay. And so that's how I learn now. It's hard as you get older to find people who can mentor you. They're still out there, but it's just different. And so for me, I learned to ask for criticism and to accept it, to learn that I can acknowledge my weaknesses, and to consider that. And then also to take a scientific approach and to think about, does this make sense to me? Some places like politics, they don't care what the results are. They just, this is what they want. Okay. For me, it's a question of give me the data and then I can make a decision about that. So it's really a combination of attitude and patience and comfort level with the fact that I don't know everything. Go ahead.
Besides your preventative medicine like specialty, how did you get involved in global health?
So I was interested in it. So I didn't make any jokes about being born at a young age in the hospital next to my mom, things like that. But my mother was a war orphan from Vienna, and I would listen to her and her sister talk in German. And so I'd be like, well, gee, what's German? And so I studied a lot of languages in high school. Okay. More important, along with that, is a strong interest in people. I like new things. I like different things. So that means traveling to different cultures and things like that. And so to me, it was a natural outgrowth of one, my interest in Europe, but also my interest in different cultures and different people. So it goes along with my interest in people. And I knew that, and I went to Hopkins in part because I knew I wanted to do something international. I didn't expect to have it such a pillar of my career as it was, but I was lucky. And one thing I should say is this: is that some of this is luck. Let's be honest, but it's 90% perspiration, 10% inspiration. You write 7 grants, the 8th one, you're lucky, you got the 8th one. Well, what about the 7 beforehand? So you have to recognize again that perseverance is a critical aspect.
I had a question in terms of using emergency visits kind of as a proxy for surveillance of health, disease outcome, exacerbation. I know the paper we read, I thought that was a really interesting kind of observation to look at as causative or indicative of disease. How has that kind of trended and how has that grown since the paper we read in 2008 and just kind of in terms of informing healthcare, preventative healthcare, and health policy?
So are you asking how analysis using ED visits has grown, not just the number of ED visits?
More the analysis, yeah, using it as kind of a proxy for disease or disease exacerbation.
So as I said before, emergency departments are kind of a window in the community. Understanding any data set you use, you need to understand the strengths and the weaknesses. By the time I finished my doctoral dissertation, I had a data dictionary that was over 100 pages long. Okay, so you have to understand what your data strengths and weaknesses are. ED visits in general, the reasons for them don't change very quickly unless you have something small like a pandemic, which would never happen, of course. And so you can look at changes over time. A lot of the data is used to look at healthcare operations and ED operations. A lot of the stuff that I'm interested in particular is looking at kind of the impact of policy, those type of questions. And so the use of emergency department data has grown substantially over the last 20 years. There's larger data sets. You still have challenges with some of the questions. But again, as a core part of the overall health system, you need to understand how it is and how it functions. Published a paper earlier, this was just last year, in which we looked at CMS pays, has a marker, looks at readmissions, okay? And so that's one of their kind of quality measures. And the question I had is, they look at readmissions in 30 days. And I said, why? Why 30 days? Okay. And, you know, because it's easy to count. It doesn't mean it's a good marker. It goes back to my issues of healthcare systems. But, and so I said, well, what happens if we looked at data that had different timeframes and had different variables in it? And we looked at that and could see there were different aspects, depending on which you looked, which disease you looked at. So that was something we published based on ED, again, using health systems data. And ED data is a health systems data.
Hi, thank you for being here. For people that are interested in EM, what would you recommend for us to make being a competitive applicant for residency? Like ultrasound's a big part of our curriculum. Should we take that all the way? Like, what are some of the things you guys are looking for? So
the first thing I would say is excel at what you do. Okay, do your day job. Your day job is to be a student. You may want to do, you know, free clinic. You may want to do other things. Those are important as well. But excel at what your primary job is, okay? Because that's what's going to get you through the door. Now, the other things you do, publications, specific interests, etc., do what you want, but be able to document it. So if you're going to do ultrasound and you do all the ultrasound, then what do you do with it? If you're going to publish, then publish, you know, what your research is. It doesn't matter. It's going to be more, what did you learn from it, and can you articulate what you learned? But first and foremost, be the best medical student you can be. Okay. Now, when I grew up, my mom said, be the best, she'd say, be the best medical student, right? The problem with that is, what does that mean? Who's the best, and how do you measure that, and all those kind of things? My preference is simply say, do the best you can do. Okay. If you feel that you've done 100% of this is what you got, then I congratulate you. Okay. If you feel like you didn't do that, well, then there's room for improvement. That's a little bit of a self-assessment, and I find that often we're our worst critics, if you will, but that kind of gives you a perspective on that. Time for one more question. Any of you backbenchers there who actually stayed awake?
I don't need to take the last one. I think I was just remarking that throughout some of your journey, it almost seemed like you might have an interest in pediatrics or young people. Usually when I think diarrhea, injury prevention, measles, you know, the little girl on her dad's lap, there was like a pediatric flare, and now you're at the VA. So I just wondered how that journey has been for you.
I'm very amnestic to age, gender, race, etc. If you have a problem, can I fix it? Can I help you? Pediatrics, and part of it is sometimes the funding source. So I actually got the KOA through NHLBI, which is long, and so pediatrics was less important. But you know, some of the other ones it may be related to where the funding source was. But for me, the unifying things is how can I improve your ability to get care in a timely fashion? All right. Again, thank you guys for your attention. I hope you guys have a great weekend. Thank you very much.